Hey everyone, welcome to Take a Pause with Menopause, where we will talk about the pause in all of her glory, not so glory. But we will have a fun and honest conversation, regardless of what we talk about. And I am here again with my partner in crime from Menopause, Debbie.
Hi.
And we are doing part two with lovely Giselle, who is with us again to discuss the tea and everything that we have to know. And Giselle is a certified menopause provider and a sexual medicine provider. So, yeah, we're going to have another episode that we're talking about the down there, according to Debbie, and sex and how do we look like a lumberjack if we take the testosterone. So,
We're going to bust that myth right here,
we
right now.
are. We're talking about myth and, just how to manage it. And yeah, we're going to get down and
Okay,
gritty.
so can we just start with myth number one, I think, which is like the myth of all times.
Yeah.
Testosterone will make me look like a lumberjack. Okay, take a deep breath. Let's address this issue because I am telling you, I was told that and I got right off it in my younger years. I was like, I really thought, oh my gosh, I just had a hysterectomy. And now I'm trying to get back with my hubby and feel sexy. And they're telling me I'm going to have hair all over. I'm like, no, 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 no. It was bad enough. I had to get rid of my whole insides. I don't want to have hair on the outside now. So,
Yep.
please talk about that myth.
Absolutely. So testosterone is an androgen, right? So we know that in excessive amounts, it can cause male pattern hair growth, male pattern hair loss, cystic acne. When we are giving women testosterone for libido, we are not in the business of turning them into lumberjacks or men or the Wolverine. We are trying to get physiologic levels back. Now, I will tell you, we've got to be aware of certain providers who may not understand testosterone, right? And the
Mhm.
testing. So I had a patient when I was the director of a testosterone replacement clinic who came to the clinic and she had hirsutism, which is facial hair.
Yeah.
Her voice was deepening. And she came in and she's like, I need help. And I was like, I am sorry. I told her, I said, I'm sorry, it's hormone replacement, right? Because that's what I thought.
Okay,
Uh,
I get it.
yeah. And so she said, no, this was not meant to happen. And I said, okay, tell me more about it. Let's talk about this. So she had gotten pellets from a provider that and there's nothing wrong with pellets if they're done the right way, right? And if you go to a provider who knows how to properly place them and dose them. Um, and I said, who did this? And she said, my provider. And I said, okay, let's talk about this. Let's talk about your labs. She goes, well, he only did one set of labs. I said, what provider was this? And she said, my gastroenterologist. And I said,
Guess
what?
Oh my gosh.
So this is something that I want to tell patients. Go to somebody who understands hormones. Go to somebody who is not doing it for revenue enhancement. You
Yeah,
want to go to somebody who understands what is happening and how to reverse that, right?
right.
Pellets, you can't take those out. Those suckers are in there. You can't take them out. You can give a boatload of medication to
Wait,
decrease the
wait,
effects, but
wait, you
Yeah,
can't
what would happen?
you have to take them out. Did they just stay there forever?
they dissolve over 3 to 4 months. They dissolve.
Oh,
Their pellets are it's a little incision that you do in your butt, and you get this trocar. It's that this isn't doing
Yeah,
justice. And you put the pellet in there, and then you shove the little pellets under the
like a glow
skin.
dart. It's like a
Yeah,
glow dart.
right?
I mean, I didn't know how I was like,
you
we
can't
could,
take it out?
You can't take those out. Now, sometimes your body can try to self-expel them,
Mhm.
but yeah,
Oof.
that's not good. So, regular testosterone dosing for women, physiologic dosing should not turn you into a lumberjack. It should not
Right.
um we are only giving women a tenth of what men get. So my guys on my men's clinic, they get 140 milligrams a week. They get, of testosterone.
Right.
My patients get 5, 10
Right.
milligrams a week, depending, right? It just depends on the patient, on labs, on symptoms, on everything. So we really, when we're talking about, when we're talking about testosterone therapy, we're talking about replacing, right? We're not talking about overdoing it. We're not talking about giving levels that are going to cause these changes. And this is why it's really important to monitor labs,
Yeah.
right? And I always counsel patients when patients ask me, okay, what about testosterone? What do I need? We need to know labs. We need to know we have certain labs. I have certain labs that I check for my patients. I always check a CBC, estradiol, um, uh, progesterone, FSH, LH, DHT, SHBG, testosterone free and total. I calculate the calculated free testosterone, prolactin levels. That's like the baseline, right? And then when it comes to reevaluating after testosterone therapy is started, then we check estradiol, CBC, DHT, SHBG, testosterone free and total. I think I already said that, but that's why monitoring is so important. And what I always tell patients, the reason why women have some of those side effects is A, they're predisposed to metabolizing super logic levels, right? Um, so their body responds differently to it, or they've just been given too much,
Too much.
right? So we should always monitor. That's so important for women and men. Whenever we give testosterone to a patient, be it a man or a woman, it has the ability to convert to estrogen, aromatase to estrogen, or DHT, dihydrotestosterone. That's an important hormone to check. A lot of providers don't check that. But DHT is what's responsible for male pattern hair growth, male pattern hair loss, cystic acne, right? The andronizing
Yeah.
androgenic effects. So we should be checking those. Um, Going to a provider that knows what they're doing is key, right? I was driving down the freeway one day and I saw pellets now offering pellets at an urgent care. And I'm like, at her urgent care, why are we,
Give
you
me a
know,
pellet now.
Yeah.
right. So
Amazon's gonna start selling them, pretty soon too. Oh,
I know
so nice.
self-administered.
Pellets. Pellets.
I
It's
couldn't do that.
no,
Yeah.
no, but
So, obviously you want to go to somebody that understands what they're doing and understands the hormone and that is monitoring the hormone,
right.
right? Just be completely honest and transparent with patients, right? That's the important part.
I think that's key too, just, monitoring it so that way you don't end up 4 months later with hair where you don't want it, and, there goes the scary part.
Now, we sometimes we can have excess growth of hair, right? Or we might notice that maybe the hair is a little bit thicker on our legs. That can happen. And if you're transparent with the patient and say, okay, these are the common side effects that can happen um from testosterone therapy. Like your hair may be oily, you may notice oily skin, you may get some acne. Those are some things that can happen, right? Because again, with hormones, the oil production increases more so with testosterone. But really monitoring it, that's important.
Yeah. Sure. Okay. Well, here, myth number 2, it's about that if it's not FDA approved, it must be like sketchy. Like I think that's something that, they made the black box warning a certain way so that people thought, oh my God, this is horrible. So now with it not having the seal of approval, like the good
Right.
housekeeping seal of approval, people are like, oh my God, it's like I'm, doing a deal, at the corner or something.
Exactly. And man, there's a lot of people and providers that make us feel like that,
Right.
right?
Yeah.
Oh my gosh, it's off label. Do you know
Yeah.
how many providers in medicine, providers across the board, that we use things off label for. So
Oh, yeah.
testosterone shouldn't be anything different, right? We use it off label. We know that it works for women. Unfortunately, it is DEA controlled because one bad bunch spoiled that, one bad apple
Bad
spoiled that.
apple,
Yeah.
right.
So now it's like a controlled substance, which it's like it's a hormone, guys. It's a hormone.
Oh, let me
Right.
tell you about that DE. So I finally was trying to get testosterone. It took forever. My family doctor, not my, optometrist, gave it to me, but it was, you know, that
Listen, as long as they know what they're doing,
not urgent care, not anything. But listen, it was so mortifying for me because I had to go. I didn't realize they were like, you need to get a urine test. And I'm like, okay,
what?
before I started to take it. I'm like, okay, that's odd. All right, fine. So I go in, the little like person comes out.
Because it's a controlled substance.
Uh-huh. Gives
Oh,
me and I go in there, she gives me the cup, she walks me into a little tiny room in a hushed tone, and I'm like, "What's
God.
happening here?" This is what I said to her, and she goes, "I'm gonna need you to go into this cup. You can't take your pocketbook with you." And I'm like, "What is happening?" Go into the bathroom, "I'm gonna stand out here." Oh,
are
yeah.
you
This is it.
serious?
She walked me to the bathroom,
This is not an opioid. It's not a stimulant. It's not.
this
So
19-year-old walks me, looking at me, and I come out and I give it to her, and then a loud-ish Jersey came out, and I was like, "I'm not a drug user. I'm here for testosterone," which then made me probably look even crazier, but I'm like and they all looked at me like as if I was, like, trying to get drugs there, and they were like, "Please leave your specimen there," and I'm like I was so mortified, I was like, "I don't ever wanna do that again." But that's
so
how it made me feel.
so then this is when you have what a teachable moment. This is what I like to call teachable moments for providers. Um,
Please teach us.
Yeah,
yeah, it's a hormone.
yeah,
It's not fentanyl. It's not
well,
Adderall. It's not, my God,
I know.
right?
I was like, "I'm not drug seeking, I'm hormone seeking." I don't know how else to
If
say
you
it.
know what's good for you, give it to me. No, I'm just joking.
That's so not
It's
fair. It is
it's
so
not.
Right?
not
Like, I
fair.
wanted to say, like, not in a but, like, "You'll find out someday," but I'm like, oh, it's gonna be lost on it because she's already said, "I have this mean lady in the little dark room there waiting for her results."
Well, but again, right? Like, aga the medical society
Uh-huh.
has made this
Yes.
like
Yeah,
we can oh my gosh,
yeah,
it's DEA, it's taboo.
yeah,
No, it's testosterone. Give
yeah,
it to me. There's nothing wrong with it,
exactly.
right? Like, again, Europe, Australia, it's acceptable there. And when a provider sits there and says, well, it's off label. Okay, well, it's completely legal. It
Yeah,
is evidence based because we have evidence that
mhm,
testosterone is amazing and that it works. And doing off label prescribing is common. I
yeah,
mean, metformin for PCOS, right? How many times do we use off label medications?
right.
So, why are we making patients feel like they're drug users
Yes.
for getting testosterone, which is crazy?
Yeah,
Why are we making them feel like it's like they're asking for something that's so unattainable? It's not.
yeah,
It's
but
it's
that is unfortunately.
it truly is unfortunate. And, you know, it's not it, it's not some sketchy basement operation,
I
right?
mean,
But a lot of times they're making it feel like it is. It's legitimate medicine
yeah,
that just hasn't gone through the FDA hoops and marketing purposes, right? And the issue truly is pharmaceutical economics. Like, I hate to say it, there's no money in making a product for women when compounding pharmacies can do it,
but
right?
also though,
Oh,
if they make that Addy that you said, right? Those
Mm.
are pharmaceutical companies.
Those are pharmaceutical
Right.
companies, yeah.
So they're like, "Oh, women in menopause have a low libido. Let's give them a quick, thick pill. We'll sell it, upsell it, and We're
Addie
making
was Addie was originally the purpose for Addie was originally weight loss, and they found that increased sexual desire was a side effect, so they sold it that way. And for the longest time, it was just for because that's the way that it was done. It was just for perimenopausal women. It just passed this month or last month. My months are combined. Sorry, for postmenopausal women.
there you
So
go.
we still, I mean, yes, we have two FDA
I want
approved.
some Addie.
Addie's great. We do have two birds with one stone. We do have two FDA approved medications for sexual desire, right?
Mm,
But they're not hormones.
Right.
Again, again, if you have a thyroid dysfunction, we're going to give you levosynthroid armor, whatever.
Correct.
If you are a diabetic and you need insulin or a medication, we're going to give you that medication. So if we have somebody who has low testosterone, which is a hormone, so is thyroid, this is just a sex hormone. It shouldn't be just a sex hormone. It's a damn great hormone.
Yeah.
Why aren't we replacing that? Right?
Right. But that's actually how I got my testosterone because I gave him the argument of, I said, if I was diabetic, would you not give me insulin? And he
Good
was
for
like,
you.
well, that's a great argument, Matt. I said, it's a statement, not an argument, just
Yeah.
the facts. He
Yeah.
was like, okay, all right, well, we'll try it. Like, okay.
Let's make sure you're getting your labs done properly and that you're doing it right.
Yeah.
oh my goodness.
Yeah.
So I think we should go to myth number 3.
Yes.
Okay.
I think I'm ready for that. Testosterone will give me heart disease, cancer, or the plague. The truth. This myth has more holes than Swiss cheese on a bad day.
Yes.
And again, I don't know why this is all about me on this. I also had family history of breast cancer with my mom. And they said, oh, well, there's another reason why you shouldn't be on it. So, I mean, I
Yeah,
was
but
doomed
history is not a
between,
contraindication for hormone therapy.
yeah. But I mean, but it's so not fair that just because there was history in my family that, you're going to get hair and you're going to get cancer.
Yeah.
Oh
Well,
my God,
we're not
Debbie.
there.
I
That's
mean,
Yeah.
why this is so intriguing to me
yeah,
that we're actually having these conversations now. I wish they would
yeah,
have had them 30 years ago. It's
Right.
so not fair
Well,
that we didn't have them 30 years ago.
it is unfair. I mean,
No,
medicine
I
is
don't like
ever
it.
evolving, right? But again, going back to the WHI, we still know that estrogen doesn't really cause breast cancer,
no,
right? It reduces the risk of it. So it's been there the whole time. We need to stop reading headlines and actually read what's in the study. Um, Testosterone's a different beast of a hormone. I say that all the time. I say that with everything. I have patients who have had breast cancer, are survivors of breast cancer, and their oncologists have actually said, yes, get testosterone. Now,
Wow.
testosterone, again, remember, testosterone can aromatize or change, convert into estrogen. But typically with my female patients, I don't see that. I see that with my guys who are getting 140 milligrams, 160 milligrams of testosterone. I see that because they get such large doses, right? Um, all of these, testosterone will give you heart disease or cancer or the plague. Current evidence does not support this fear. You know, some so there are some studies that actually suggest that that there's cardiovascular benefits, right? We
Mm,
should always be monitoring cardiovascular factors.
right.
Um, we should always be monitoring that. And in truth, cholesterol, because that's a huge one, right? A lot of people say, "Oh my god, my cholesterol." I look at cholesterol a lot differently than most providers do.
Mm,
Cholesterol is important. We need cholesterol for cognition. Our brain needs it. Our brain needs cholesterol.
mhm,
Our sex hormones, DHEA, progesterone, estrogen, testosterone, are all derived from cholesterol, right? We need to be looking at the cholesterol that causes a lot of issues, like triglycerides. We need to be looking at how can we increase our good cholesterol, our HDL. That's what we need to look at. Um, and it is known that hormones, right? When your hormones are all in balance, all good, that it actually helps promote cardiovascular health, right? So those are um, those are all important, right? Estrogen, testosterone. Testosterone's not out there. It's not trying to murder anybody. It's not trying to kill anybody.
Right.
It's not trying to give anybody cancer, right? So, um, again, right, with cancer, there's no evidence that links appropriate testosterone therapy to breast cancer. Um, there's actually some out there that says it may be protective,
Yeah.
right? And as long as we're monitoring it, right, and having women do their screenings like they're supposed
Yeah.
to, we should be good. Um, there's I don't know where these myths come from, and I don't know if somebody's confusing women's testosterone doses with male bodybuilder doses. Um,
Mm.
we're not competing in Mr. Olympia here. We're just trying to get our motivation, our desire, and our sex drive back. Now, I will tell you, I have some patients who are body competition. My female patients, some of them do body competition, and it's amazing to see what testosterone
Mhm.
does for them. They're
Mhm.
not overusing it. They're not abusing it because again, they have me as their provider and I won't allow that. Right.
Right. Right.
So that, that is, there's a difference in that. Right. Um, Testosterone is a great hormone as long as it's not being abused. And so
Right.
it shouldn't cause any of those things, right? Definitely not the plague. Hopefully not. Then we're all screwed.
I don't even
Right.
know where that came from. That's
Yeah.
like,
Well,
I
that's
Right.
thought that was done.
yeah. Well, the myth, another myth is that, again, like what we were just saying, people feel like if estrogen doesn't fix everything, nothing will. Like, and again, it's like, it's like sort of like that analogy that you say, well, I tried coffee and I'm still hungry. So clearly food won't either.
I like that.
You know, like,
Right.
well, you keep trying until you find what works for you. Like, it's probably not, for me, I know in my experience, it wasn't like a one stop shopping type of thing. I had to figure out which patch worked best for me. Then I was able to get the progesterone. Like, I've just been building my pyramid back.
Yeah.
So I
Right.
think women just have to realize it's not a one, oh, this didn't work. That's it.
And Mare, there are some women out there who are like, estrogen, progesterone did it for me. That is fantastic.
Right.
Great.
Yeah.
Right.
Exactly.
There's other women who are like, oh my God, what the hell? I need, and that's why I like to call it the trifecta. We
Yep.
had it in the past. Do we need it again? Possibly, right?
Yep.
Especially if we are on estrogen, on progesterone, we're not feeling ourselves. What
Right.
else? What's the missing puzzle piece?
Yeah.
Patients come to me, we go over their labs. They're like, "Well, what would you do?" I'm like, "Well, I'm on testosterone, so I don't know." I know what I would do. but but um but then I tell patients, just because it's right for me does not mean it's right for you,
Right.
right? But if you want to try it, we can certainly do it. We have to give it its fair chance, right? Because again, it's not a magic wand. It takes time, just like everything, to see how your body responds to it. And so, um, many women need all three hormones to feel amazing.
Right.
Um, Especially when it comes to libido, right? And motivation. They Once they get started on the testosterone, they're like, "Oh my God, where has this been all my life?" I'm like, "Well, it's been there. It's just we needed to get you on it." Right. So
Right.
um we really as providers should have that conversation with patients about what hormones are out there and be able to speak for them. And listen, I always tell patients, if I don't know something, I'm not going to say I don't know. I'm going to say, let me find that out. Right.
Right.
Um, Providers need to do that. If I don't know how to do it, or if I don't know how to prescribe it, man, phone a friend, send the patient somewhere else to do
Yeah.
that. Right. Um, because there's so many health benefits to it too. Right.
Oh, yeah.
There's articles, there's research studies. We're talking about osteoporosis in women. Okay,
Mm.
why aren't we giving them testosterone therapy to help bone health? It's not just estrogen, testosterone too. Think about it. Oh my God, having both of those on board, doing weight bearing exercises, you're gonna increase those chances. You're gonna reduce those chances of having a bone fracture and osteopenia or osteoporosis. You're gonna increase their bone health,
Yep,
right? Why don't we want that?
So
exactly.
if you already are post menopause and you already have bone issues and you haven't worked out, is it too late to start?
Nope. It's never too late.
Because
It's never too late.
I'm on that path now. I'm,
Yeah.
you know, at gonna be 67 and I'm just now starting all of this. And I wish I would have started earlier, but I feel like it's not too late. So if you're out there and you're thinking about it, you know, think about it and, you know, talk to your doctor and go to somebody, you know, like you that knows the hormones. Just don't go to anybody. Because
Right.
it's really important that we have somebody who actually knows and will test for each of us are different of what might work.
Right. And that's really you know, that's really important to um when trying to I always call it the treasure hunt, right?
Hmm.
Trying to find a provider, right? Now we know all this information. We're given this information. Now it's like, oh my gosh, where do we go? Who do we go to? Um, and it's a treasure hunt because again, a lot of providers don't know testosterone, or they'll say, okay, well, we'll try it and not even test, or um, they'll send them somewhere else. Um, I can tell you that for me, having an open conversation with the patient, um, telling them, and some patients will ask me, well, is testing necessary? And when I break it down to why we do the tests that we do, I order the tests that I order, because again, not all providers practice like I do. Um, but when I order those tests and I explain it to them, they're like, oh my gosh, that makes so much sense. Right. So the treasure hunt um, can be the hardest part, trying to find a provider who actually knows about testosterone therapy for women. Sometimes can be like finding a unicorn or searching for a unicorn. Um, you do want to look, not all menopause specialists specialize in testosterone. However, you can go you can go to the NAMS, right? Menopause certified specialist, the NAMS website. Um, it's a great place to search for um, menopause providers. I'm on there. Functional medicine providers can also be a good source.
Mhm.
Some gynecologists, right? Depending if they have that.
Right.
Um, and then, going to a compound pharmacy. Hey, what providers do you work with, or what providers call in compounded testosterone for their women patients? Go to compounding pharmacies. I love working with local compounding pharmacies. One, the pharmacists are always great. They're always so knowledgeable and ready to answer questions, not only for the patient, but for the providers. But if a patient calls and says, hey, I know you may not work with somebody, but do what providers write scripts all the time that go to your pharmacy? That's a way to do it too. Um, ISWISH, the International Society for the Study of Women's Sexual Health, is also a platform where you can find a provider that may do testosterone hormone therapy. So those are some areas that you can, or some places that you can find a provider. Some red flags for
Yeah.
patients, and
I
this
was
is a
gonna
huge
say
one.
yes. What do you yeah. What are, like, the red flags? Like,
Yeah. Um, when a provider says women don't need testosterone,
"Okay,
turn around and walk away and say,
yep,
okay, thank you. Um, Providers who's never prescribed it before and seem scared. Um,
yeah,
so if you go to your provider and you're like, hey, I want you to prescribe this for me, and they're like, oh, well, I don't know, I guess I can Google it. And like, no, you want somebody, you want somebody who
yeah,
has experience, phone a friend,
yeah,
right? Um, this is the big one. A provider who does not want to monitor labs. Nope.
Oh,
yeah, nope, nope, nope."
No. Again, there's a lot that can happen with testosterone and not monitoring, right? A lot of providers don't know that the primary secondary effect of testosterone therapy is increased hematocrit levels, right? So that's part of your blood. It can cause your blood to become thick.
Yeah.
If you have a high hematocrit, you're now risking secondary effects of maybe a blood clot, right?
Right.
My guys, I do this for my gals too. Um, I have some that every 3 months they have to go do um therapeutic phlebotomy, donating blood, right? Because
Huh.
it decreases their hematocrit. It it um it helps decrease the viscosity of the blood, right? Those blood centers, those I'm telling you, they love guys or gals who are on testosterone who have to
Hmm.
have blood draws, because then they're giving blood every 3 months or maybe every 4 months. So it's kind of, so you want to monitor your levels,
Yeah.
not just for high testosterone levels, but the hematocrit levels. That's something that needs to be monitored.
Hmm.
So really important. Um, and what I like to tell patients, if they're not coming to me or if they're or here in the podcast, um, interview your provider. You as the patient have the right to ask your provider, how many women have you treated with testosterone?
Hmm.
What method do you prefer and why? Pellets, creams, injections, troches, oral. Ask those. Um, how do you monitor levels and side effects? What approach do you take if levels are high and need to be adjusted? You are hiring a provider to feel better. You are investing in your health. And I tell patients all the time, you have the right to hire and fire any provider, including me. If they feel uncomfortable by you asking them questions, that's a red flag.
That is that is key. That is absolutely key because that is y- that's what happens, right? So
Mhm,
you're like reluctantly have somebody be like, okay, fine, if I can get you out of my office, I'm gonna write this for
mhm.
you. And then
And
you don't
then what? And
and then
now
exactly,
yeah.
and then it's like, okay, I have to go get a shady, blood or urine test, and now there's nothing.
Like,
And
did you do a urine
what
test?
and yeah, and I can tell you, I never went back. And yeah, the yes, I've not had my levels. So
It's
guess
unfortunate.
what we learned here today, girls?
Okay. Summarize what we've learned because it's
Summarize. I'm
we're
gonna get
we're going
levels
deep.
done, but I mean, it is just still we are here, like we said in the beginning. We started the first part. This is part two because the Valentine's Day is coming. So we're going to put a beautiful bow on this because it is the gift of knowledge.
It
I
is.
mean,
Knowledge is power. I always say it.
it is. And I've had so many aha moments just through both parts of this, and I know women out there have too. So we know again where you said that you can find a provider, and I will put that at the end with the notes from the
Perfect.
show so that way everybody can find out. But just basically, yeah, get ready to hire
Mm,
your provider. It
yes.
don't take whatever your work says that you have to go here, whatever. Do the work because you're worth it. And that's the most important part.
It's your investment.
Yes,
And
it is.
truth be told, this is the most frustrating part. And it's not just for women, because this happens to guys too. Again, insurances play a role, right? It is not covered by insurance. So a lot of it is an out-of-pocket expense, which is not cool. But if you have an HSA, FSA, check your plan. You can use that. Most blood work, if you have insurance, should be covered if it's billed appropriately. It should
Correct.
always be billed appropriately, and there shouldn't be any issues with that. There's other places that you can go to if labs are too expensive, um, right? So there's other places that you can go to. So those are some of the things that can be discussed with
Right.
a provider as well, to guide the patient. And that should always be discussed. I always try to discuss that with my patients.
Yeah. So basically, yes. So that is the key takeaway. This both parts of this were a present for Valentine's Day, but not just for your partner, for you, mostly important to get it because testosterone is essential.
It
And
is.
that is something that we have to understand that it's not an optional. It's not optional or not needed. It is a discussion that needs to be had, and it is essential that women get out there and who are pre, peri, post menopause, because as Debbie, we just learned here, it's never too late, which is also something that's very important to know.
Right. And that is the
That's a
key.
gift. That's a gift right
That
there.
is,
It's
yes,
never too late.
it is
Well,
never too late.
it's never too late. But just remember, right? We've been told for the longest time, you can't, after so many years, you can't start hormone replacement therapy. You can't do X, Y, and Z. There's a lot of things that are still very antiquated in the way that women are being treated. And I always tell patients, do your research, be your own advocate. You're going to have to be. Um, it's never too late.
It is never
But
too
You
late.
deserve to have sex too.
Yeah. Yeah.
So yeah.
I mean, there's Debbie. I love how she blushes when you say
I
the
know.
word vagina or sex.
Oh, okay. So wait.
Ah,
No, hold on. There was something I forgot to add. Something I forgot to add, ladies. So
What?
poor Deb. She's like, her face is turning red. So the vestibule of the vagina and the bladder have testosterone rich receptor sites. Meaning,
Oh.
yes,
no,
meaning,
we got her attention now.
yeah. So a lot of times women may also need a vaginal testosterone cream to help kind of get things going. But there's intrarosa, which is DHEA. See, I can go on for days about this, girls. There's DHEA intrarosa that is the only medication at the cellular level that changes to what your body needs. So it will occupy the
Oh,
estrogen receptor sites and the testosterone receptor sites. And it's amazing. But yeah,
okay.
And
That's a
what
whole
was that
other
called again?
topic.
intrarosa, it's this little guy.
Oh, you have it.
Yeah.
Oh.
You should see all the tools. I have visuals for my patients.
I
By Lisi.
What? But how
right.
do you get? Wait, how do you even bring up the subject of interrose, whatever,
Well,
interosa?
she just did right here. I think it's
I
that.
know, but how do you say to your doctor? You
Oh,
heard it? They may not even know about that. They may not even want to
Yeah,
suggest that.
well, then you just say, "Hey, listen, I have recurrent UTIs, I have vaginal dryness, I have painful intercourse,"
Yeah.
all of those. So just last year, the American Urology Association cleared intrarosa as a treatment for genitourinary syndrome of menopause.
and that's the other thing that we are definitely going to have a whole episode on that because
Yeah.
uh, that's a whole syndrome. That's a whole different part of what happens because everything down there, as Debbie would say, is so close and you get so many,
Let's see if I can
as Giselle is holding up her intrarosa.
Yes.
But that, girls, I'm telling you, that is going to be our next one because that is a topic because then the whole pelvic floor and
Yeah.
all that, it's going to be a pelvic floor situation.
Let me
Okay.
tell you, so as a sexual medicine provider, not just as a sexual medicine provider, I think as a menopause provider, I think as just a provider, we should have in our toolbox a sexual therapist. If you don't know where to get one, go to ASECT. ASECT is the organization for sexual therapists. Providers should have a sexual therapist that they can contact, a pelvic floor therapist, because every woman needs pelvic floor therapy. I don't care what they say, every woman should have pelvic floor therapy. And phone a friend, right? A friend that you can
Oh, I like that.
confide, a colleague that you can be like, hey, I'm not sure. I had this patient who she presented this way. What are your thoughts? So that's just for providers. That's what I say
Yeah.
for providers. But
Okay.
as a patient, I would want to know, hey, things aren't going so great. Where do I go? What do I do? I think I need a sexual therapist. Providers should be able to say, hey, go to this website, or there's this organization. You know, I'm having issues with my pelvic floor. Go to a pelvic floor therapist. It is so important.
It is important. And that will be our next one, girl. See, we just go right to the next. So
Oh,
I
yeah.
just want to thank you so much, Giselle, for giving us all the information as we talk about the tea. And we know that the tea is important. And I'm thankful for this, not just for Valentine's Day, like we say, but
For
Yeah.
all,
every day.
For
all
every day.
For
For
every day.
overall health, right? Investment in our health for sure.
yeah,
Yes.
invest in our health. So thank you again.
Thank you.
And yes, again, so many aha moments. I've appreciated it. I'm sure that our listeners have, and I can't wait to talk to you about the pelvic floor.
Okay.
All right.
I'm
Well,
not good
thank
at
you,
that, but
girls.
there we
Thank you,
go.
everyone. And like I always say, we will see you next
Next
Tuesday.
Tuesday. Awesome.